Okay, so I think I'm going to welcome Lee Sanders up to the podium to introduce today's speaker. I will say we had to arm wrestle to see who was going to introduce Peter because there were a lot of people here in the room who are huge fans of Dr. Margolis and his work, but Lee has the honor today. So thank you, Lee.
I won the arm wrestle only because Dr. Leonard gave in. She's much stronger than me. It is a great privilege for me to introduce to all of you Peter Margolis, who just this year has joined us as an adjunct professor of pediatrics here at Stanford. He's also emeritus professor of pediatrics at the University of Cincinnati School of Medicine, where he's former co-director of the James M. Anderson Center for Health Systems Excellence at Cincinnati Children's. How do you describe Dr. Margolis? He's really had a non-traditional path. And for those of you in the room and online who are interested in carving non-traditional paths in science and medicine and health systems, I think Dr. Margolis is a great role model and seeks to be a mentor and to help each one of you. He started with a traditional path. He completed his MD at NYU, residency and chief residency at University of Colorado. And then several years later, got a PhD in epidemiology at the University of North Carolina. While many of his colleagues were seeking understanding about systems at the cellular level, translational research at the level of the organ system, Dr. Margolis became captivated with a different level of system, and that is the healthcare system. And in fact, the many healthcare systems in which our patients and ourselves navigate day to day, moment to moment. And over the past 20 years, he and his research teams have developed innovative approaches that engage patients, their families, clinicians, scientists, and communities in developing network-based learning health systems, which I'll describe more to you in a second, that simultaneously improve care, spawn innovation, and accelerate research. He was a co-PI, in fact, on an NIH transformative research grant that's focused on developing learning healthcare systems for children with chronic illness. He served as chair of the PCORNet Council, which transformed research infrastructure in the United States to really keep patients and families at the center of care, and has been a driving force behind PedsNet that we're lucky to be involved in as our institution. And the Improved Care Network, which he now leads, and if I have this correctly, engages more than 70% of children and adults in the United States with inflammatory bowel disease in improvements of care, has been awarded a number of prizes and really is a great model for learning healthcare systems. Dr. Margolis is an elected member of the National Academy of Medicine, and in Silicon Valley, you always have to check ChatGPT or Gemini. So I checked it out for his number of publications. According to Gemini, he has more than 12,000 publications in the peer-reviewed literature, which I was really amazed by when I looked that up last night. I don't know how you do that, Peter, with all the other things that you do. Peter has also been a warm mentor to me and many of the others of you around over the past several years. And he really endeavors in this new phase in his own life and career to help each one of you, to imbue those of you who are looking for it with courage to move forward and really help change our healthcare system for the better for all kids and families. So Peter, privileged to have you here. Take it away.
I'm so happy. I am really happy and excited to get to do grand rounds this morning and share a little bit with everybody. Some of you are current collaborators in a lot of the work that I'm going to talk about, we'll just recognize you as we go along. So today I really want to talk about the architecture of health systems, and I'll use a bunch of examples from work that we're doing just to share some disclosures. I am scientific director of the Improved Care Now Network, a new network focused on bipolar action, and an advisor to a technology company called Hive Networks. I want to start with a question that sparked some learning. This is from a dear colleague that many of us know, and he and his wife are now open about who they are. And so this is from Rob Kahn and Jessica Kahn about their son, Seth, who was a patient at Cincinnati Children's. Rob Seth was diagnosed with inflammatory bowel disease in, I think it was about 2015. And Rob and Jess were concerned about whether or not there might be something that was possible to get Seth into remission. And so they wrote to Sander Vinks, who was the head of pharmacology at Cincinnati Children's, with this question about whether there might be a better way to manage his Remicade levels. And Rob, who's a constant innovator, asked, might Sander have some experience with therapeutic drug monitoring? And if not, maybe it was an area that where the cost of the drug and the risks of subtherapeutic levels might be addressed. And the gastroenterologist in the room will have to tell me how widespread therapeutic drug monitoring was back in 2015, 2016. But what happened next was that Jessica gave Sander this spreadsheet. This is the spreadsheet that she kept of Seth's Remicade levels, his height, his weight, starting from the day he was diagnosed in February 2015. And so Sander took this data and turned it into a predictive algorithm, which is shown here. They changed his dosing schedule, and Seth went into remission and stayed in remission for a significant period of time. Phil Minar, who worked with Sander and Ted Denson and Michael and Mitch, and was very interested in therapeutic drug monitoring, and took the algorithm, worked with Sander, and turned it into an EMR, integrated therapeutic dosing algorithm, which first ran at Cincinnati Children's and then was subsequently funded as an NIH funded R01, looking at therapeutic drug monitoring more broadly. So this first question about drug dosing wasn't really just a clinical question. It was a systems question, and it sparked a whole cascade of learning and collaboration and innovation. And so this story captures the idea of a learning health system where questions from the front line lead to discovery, where patients and clinicians co-produce solutions, and where data and expertise flow to where they're needed. And that's really what I want to talk about today, how we build systems that can do this, not just for a single patient, but for populations of patients. And so when I listen to conversations about learning health systems, I often hear an emphasis on the parts. How do we improve informatics? What if we used AI better? How could we accelerate research? How can we change the culture? And that focus on the elements or the parts is not the system, not focusing on the system itself. It's focusing on the parts of the system. Russell Akoff was a pioneer in systems thinking, and he put it this way: if you take the best parts of the car in the world, if you take the best steering wheel from a Lexus, if you take the best engine from a Maserati, if you take the best tires, the best brakes from a Porsche, and put them together, would you get the best car? And the answer is, of course you wouldn't. And that's because, and what you would get is a pile of expensive parts that don't work together very well. And that's because what gives a car its essential property is not the parts themselves, but how they are connected and how they work together towards a common purpose. In the case of a car, it's mobility. And so the same is true for the example that I just showed. The value didn't come from the components, the clinical care, the lived experience, the pharmacology, or the data from the system. It emerged from when all those things were integrated to get a single child into sustained remission. And so Akoff's point is, it's kind of simple, but it's also profound. Systems don't fail because of bad parts. They fail many times because of poor connections. And that's in many ways what our health system is facing. We have world-class research, we have top hospitals, we have breakthrough discoveries and innovations, but they aren't bolted together terribly well. And too often what we're focused on is optimizing the parts, and what we need is a way to optimize how the parts interact. this definition of a learning health system that was published in 2006 by the National Academy of Medicine is still probably one of the clearest articulations of what a health system should do. The idea is that science, informatics, incentives, and culture should be aligned for continuous improvement with best practices seamlessly embedded in the care delivery process and knowledge captured as an integral byproduct of the care delivery experience. That's the idea, and the learning. This definition of a learning health system highlights the importance of alignment and integration. But it's also fair to ask, why hasn't that vision been realized? The short answer is that our health system, in all its excellence, isn't really designed to function as a system, much less a learning system. And across various sectors, healthcare, payers, public health, research, industry, we all face similar challenges that are listed here. There's a coordination challenge where health systems in various sectors are each pursuing their own goals. There's a capacity problem where we really don't have the need to meet the myriad needs of patients and clinicians and other stakeholders in a personalized way now, anytime, anywhere. And then we also have a distribution of labor problem about who we assume can actually participate in designing care. And these challenges are system properties. They're not technical barriers. They emerge from how the parts are organized and how they connect to one another. And so that's what a learning health system is really about. It's not about a project. It's not about an initiative. It's not about a program. It's about a design. And it only becomes operational when we design and create for specific interconnected people and processes. And that's really what I want to talk about today, how we catalyze the design of systems where learning is continuous, embedded, expected, and also shared across boundaries. Every learning health system follows pretty much the same basic learning process, which is illustrated here. Patients and clinicians and health system leaders identify an outcome they want to change. They measure performance. People who can improve the system work to close gaps in performance. That reveals unaddressed problems, which researchers and others may notice. They go to work on applying methods to addressing the gaps in care. Those results are shared. Patients and clinicians and improvers implement the new approaches. And so there are three, when I think about this, there are three main parts of this cycle. The first is what you might think of as meaning teams decide what system they're actually working on and that might be a defined population or a defined entity. They use specific methods for changing and learning, and then they put into place a measurement and evaluation system to optimize the care over time. But if learning is going to be a property of a system, then it needs infrastructure, it needs connective tissue, the things that hold all of that together. Things like leadership to keep everybody focused on outcomes, or governance to allow data to be shared, or systems change capabilities like improvement methods, or specific ways of engaging patients, as well as data and technology and research that fuels this. So think of the infrastructure as the connective tissue for a learning health system. Learning is possible at every scale, whether it's a single patient or a care team or a national network. The learning process, the cycle is pretty much the same. What differs at different levels is the amount of infrastructure that's required. You can improve care for a single patient with a piece of paper and Excel spreadsheet. To improve care for a national network, you need a lot of other things. You need data use agreements and policies, data interoperability, all kinds of things that are much harder to put in place. So this is an essential distinction. The learning process describes the steps that individuals and teams follow. The infrastructure is the foundation of the people, the data, the purpose that allows everybody to work together. And that's in many ways an architectural challenge. Without the infrastructure, learning remains local, and with infrastructure, learning compounds both within and across organizations. So improvement isn't episodic, but ongoing. The story of the Remicade dosing is an example of N of 1 learning infrastructure. The basic process, test, measure, learn, adapt, that can happen at any level of scale. But the infrastructure that got built, going from an Excel spreadsheet to a dosing algorithm to an EMR integration, is what allowed the learning that took place from a single patient to be scaled to thousands of patients. So when you think about scale, how you organize work matters. And I'm just going to ask for a show of hands. How many people know what Microsoft and Carta is? Great. So many of you are too old or too young to have known that Microsoft and Carta was created as the first digital encyclopedia by Microsoft. They hired the best. They actually, I think, bought out Encyclopedia Britannica, which, if you're my age, you remember as this big stack of books that you got delivered to your house. But in the early 2000s, along came Wikipedia. It was obviously a complete game changer. It was faster, broader, more relevant, but not because it had more money. It was because it was organized differently. This is a New York Times piece from 2009, which still makes me laugh, describing the demise of Microsoft and Carta by Wikipedia. And if you see in January 2009, Wikipedia had 97% of the visits that the web surfers in the US made to online encyclopedias, compared to 1.2% of Microsoft and Carta. So, a fascinating story about how millions of people could beat big tech companies, particularly relevant here. So, Wikipedia moved from an approach that organized producing knowledge like a factory to a living system that keeps learning, and that was open, connected, and continuously improving. So whenever we talk about system design, it's easy to slip into a mental model of hierarchy. Who's in charge, who leads, and who decides? So let me just shift your perspective a little bit with this diagram. There's an old story that's probably apocryphal about how early ecologists studied why geese fly in a V formation. The story goes that to test this hypothesis, the ecologists decided to do an experiment. They went into a field, waited for the geese to fly over, and shot the goose at the front, the lead goose at the front of the V. And then what happened? Well, absolutely nothing remarkable. Another goose just took its place. And the flock instantly reorganized. The V reformed and the flight continued. That's because the intelligence wasn't in the goose, wasn't in the leader, it was in the system. And the flock wasn't, if you're a flock of geese, you're not waiting for instructions from the lead goose. You're designed biologically to adapt. And this is the reason why I like the example is it's a perfect example of coordination without command and control. And that's the principles at the bottom: the shared purpose, the shared data, knowledge, and shared visibility, and the shared simple rules. People talk a lot about simple rules for geese. In changing systems, the simple rules have to do with how we learn and how we share technology. And the point here is that this is this is exactly the point that I think we're missing in healthcare. We keep trying to optimize the lead goose, the lead clinician, the chief, the best technologist, the expert, rather than designing systems based on the science of complex systems and interconnections so that the whole system can respond and reconfigure in real time. And that's really a feature of distributed leadership. And so that brings us to the real design question. What if we could design a system like a machine, not like a machine or a factory, but a system designed for people? What would it look like if we organized our health system the way nature organizes complex adaptive systems, not command and control, but coordinated, distributed, and continuously learning? What if we built for that? And so that leads me to the work that we started back in around 2010, when my colleague and I, Michael Said, wrote this proposal. These were the specific aims from our NIH Transformative Research Award. We wondered, what if we could create a better care system by harnessing the inherent motivation and collective intelligence of patients and clinicians? And what if that system allowed patients and physicians to share information, to collaborate, and to use their collective creativity to improve health? This work led to the development of learning health networks as we know them today, a large-scale instantiation of the learning health system vision at scale. And so these are some of the results that we've observed as more of these networks have formed. The first is from the National Pediatric Cardiology QI Collaborative, which produced 40% reduction in mortality for 95% of the kids in the country with hypoplastic left heart syndrome. They've shown that they can generate evidence and put it into practice in less than 3 years. Rob Kahn's day job, when he's not being a dad and being a physician, is working on community health. And these data are from his work, and Andy Beck's work in Cincinnati. The All Children Thrive Network has produced around a 20% reduction in bed days for kids from the poorest neighborhoods in Cincinnati. So I want to return to that email, the single question that was part of a broader effort to improve the lives of kids living with inflammatory bowel disease. And this was the first network that we organized. Mitch was there when this concept was conceptualized, and had a big part in actually getting the whole effort launched by Dick Coletti back in 2005. So this at the time the network was called the PIBD Net. The name was subsequently changed. And I'll just, because I've been deeply involved with this network, since its formation, I'll use it as an example for today. So today, this is a graph showing the improvement in remission rates for the network. I took this as a screenshot about 3 weeks ago. So it just shows the improvement from about 78% in 2015 to around 83% today. Today, Improved Care Now is about 100 care centers. It's about 2/3 of the kids of the country with IBD. It's about 1,000 physicians. And the underlying technical architecture is what we think of as a triple use registry. We use the data for clinical care, for improvement and research. It's not perfect, but it gets the job done well enough to stimulate knowledge sharing and know-how sharing, which is really what's driven this improvement over time. And Mitch and Michael and John have all been leaders in actually producing these results. My role is to actually work on the system side. So for those of you who are not familiar with how a network works, I'll just quickly review that. Each site has a team of a doctor, a nurse, a patient, some local IT support. They send data from every encounter to a central registry. Then there's a network support infrastructure that includes QI expertise, QI coaching, technology, project management. They get back reports, outcome data quality, QI training. There are twice a year meetings of the network where all the teams come together, and there's best practice sharing. So what data sharing, transparency in the network and a culture of openness is a big part of what takes place. And so this is a screenshot of the data about individual care centers' performance. You can see them lined up on the left-hand column, and across the top are the measures that the network tracks. This is transparent to the entire network. You can see that everybody can see what everybody else's performance is, and there's routinely calls back and forth when somebody wants to learn about what another site is doing, stimulated by observing what their performance looks like. There are also reports that are available to sites that enable individual clinicians to manage their population, to stratify their population according to disease severity, a variety of reports that are available. So data sharing is a big part of the network. And another big part is the creating community and building co-production. When we started this work back in 2010, we worked with designers who were from Silicon Valley to help us understand the experience of people living with inflammatory bowel disease. Bianca Simmons is not a real young woman. She's what designers call a persona. She's a representation of a particular segment of a population of people living with a chronic illness. And Bianca is interesting because she not only wants to keep her symptoms at bay, but she also wants to be a leader in the community. She is the kind of person who has made living with this condition part of her life and wants to contribute and to the design of better systems. And so when we recognized that there were individuals like Bianca in the population, we wondered if we could really focus a lot of our work on designing the system to work better for them, because we knew, based on the work of someone named Eric von Hippel from MIT around a topic called lead user innovation, that a small percentage of people in any community innovate and want to make the system better, and that if you design for those people, they anticipate the needs of the rest of the system and can suggest ways of improving the system. Sammy Kennedy, who's shown on the left, and Jenny David are real young women. They joined Improved Care Now when they were in college. I think they were freshmen in college. They heard about Improved Care Now through our social media posts, and they organized what is today called the PAC, the Patient Advisory Council. It's a group of kids, some of whom as young as 13 or 9, who are actually are part of the network and are part of creating tools and resources like the ones shown on the left side of the screen that are relevant for addressing problems that kids like them have. The first thing that Sammy and Jenny created was our ostomy toolkit. It was focused on how to share with your friends what their experience might be like when they had a friend over for a sleepover or went to a swimming pool and they noticed their friend with an ostomy. And they recruited some of the doctors and nurses in the network to help them validate that. They subsequently have published a number of papers. Sammy is now a pediatric hospitalist at Nemours in Florida, and Jenny is she's an IBD psychologist. She's a psychologist focused on kids with IBD. She just moved from Nationwide to Dartmouth. So there are all kinds of stories about how what we went through with journal editors when they were getting papers from patients who they didn't quite expect to be writing papers. So you might say that people like Sammy and Jenny are not like your average young girls, and you'd be right. People have to go through an experience with an illness in order to get to the point where you're like that. They might start by just coming to become aware of the network through blog posts, using tools or signing a consent where they're participating in some way to making a contribution, like joining a QI team or becoming a mentor, or finally achieving a level that we call ownership, where they're actually creating tools, leading teams. In any network, this distribution of people is not uniform, it's skewed, it's highly skewed. So there's only a very small percentage of people who are the owners and contributors, but networks like but all networks that we participate in, like Wikipedia or TripAdvisor or Yelp, depend on this skewed distribution. So let me just ask, is anybody a Wikipedia editor here? Yeah, so we're all happy for the 10,000 Wikipedia editors who make the other billion of us the kinds of tools and resources that we're very happy to use every single day. I think probably a few more of us occasionally post on TripAdvisor, but that's the way networks work. That's the way you make them achieve their effect. That's how Wikipedia put Microsoft and Carta out of business. And what's interesting is that this distribution doesn't just apply to patients, it applies to everybody in the system. So doctors, nurses, dietitians, school teachers, everybody has this kind of distribution. So if you build for that, if you understand that you're building to unleash the capacity of this small percentage of people, you can achieve very big effects. So I just want to put a fine point on it with this video that was created by a kid who was at the time 9 years old. This is Zach Wall. He was an early adopter of enteral nutrition for his Crohn's therapy. His dad, at the debate in the Improved Care Now network, was that pediatricians at the time, the way this was done was kids put down NG tubes every night, had enteral formula dripped in every night. And the pediatricians and nurses said, kids would never allow us to do that. So Zach and his dad decided they'd create a video to show what it was like. And so I'll just show this.
Hello, everybody.
Oops. I guess the one thing we have to do.
I would like to show you, well, I have Crohn's disease,
Let me just,
as you know from my first part.
let's just stop for one. Just have to do one thing. Get a little sound. There we go. Let's try again. Whoop.
Hello, everybody. I would like to show you, well, I have Crohn's disease, as you know from my first part, but I've upgraded my 2 feet so that I can actually do it myself every single night now. And well, I want to show you. So if you didn't see my first part, go see it or just watch right here. I'll show you how you do most of the stuff. So this is the nasal gastric tube. Am I saying that right? Nasal gastric tube and nasal gastric tube. Yeah, now I said it right. So this is goop that you have to put a lot of it on. What is that goop actually called, Dad? Step 3. Hold the tube near your nose so you get the smell of it. And then you'll get relaxed and you can put it down. For me, I have to go to the second black dot. So now we tape it to my face.
Yeah, so just think about what it would take to make that video at Stanford and post it on the Stanford website. Who would have to sign off on the release? How much would it cost to hire the video company? Zach and his dad made this on their flip phone, shared it with the network, posted it on the website. So what's interesting is what happened next. So this stimulated an interest in the network in in understanding what patients' experience might be like. And what grew up was almost like the ALS challenge, where people poured water on top of each other's heads. But the idea was, let's see what it's like to put down an NG tube. And so here's a screenshot of Brendan Boyle, who was the head of the nationwide GI clinic a few years ago, and the rest of his team, who decided that they ought to experience what this is like. I don't know, have you guys done this here as a team? So what I always say is this is bottom-up motivation. If I, as a leader, went to the GI clinic and said, hey, you guys ought to put down an NG tube, HR would be like calling you within 30 seconds. And what emerged was a whole bunch of blog posts and diaries from doctors and nurses around the network about what their experience was like living with an NG tube for 24 hours. So that's it. When I talk about motivation, that's what I'm talking about. The last part of the network infrastructure, the architecture, is the learning capacity, and the crux of it is improvement methods that everyone is familiar with. But the network has been used to some extent to support clinical trials, observational studies. This is a report that, again, the gastroenterologists know about, but this is a pragmatic trial that was led by Mike Kappelman on something that at the time was a controversy, whether or not to use combination therapy with biologics, methotrexate plus a biologic in kids with Crohn's disease. These are the results. It is, I gather, the largest trial ever done in pediatric IBD. It was about 350 patients. You can check me later if that's not the case. At some level, it's disappointing to me that the largest trial ever done in pediatric IBD is 350 patients, but it had a very interesting outcome. It showed that the combination therapy for infliximab, these are the survival curves on the left, did not make a difference, but for patients on adalimumab, there was about a twofold improvement in long-term remission. It's a controversial result, and the network is now involved in a dissemination and implementation project focused on what to do with these results. But throughout the network, with an organized network like this, learning opportunities show up all the time. One of the interesting parts of the network is that the use of data by patients, patients' data for research requires consent. And what is shown here is on the left is a funnel plot. It's the percent of patients by center consented. And what you can see is about half of the centers routinely are able to consent their patients. The other half find it overly burdensome for many reasons to achieve consent. So with data like these, it's stimulating ongoing work about alternative consent approaches, shorter consent forms, requests to the IRB to obviate the need to get assigned consent. And we're in the planning stages for a actual trial to compare alternative consent processes to see if we can increase the percentage of patients who are consented. And obviously something that a more informative consent process would increase the understanding among families about how their data are used, increase the representativeness of the sample, and also create generalizable tools that could be used for other networks. As we've seen, building a learning health system takes more than infrastructure and tools. It takes intention. And when I think about it, there's a learning system part of the network, which emphasizes the methods, the tools, and the data that make learning possible. But you can't build a learning system without also cultivating a learning mindset, the behaviors that create the fuel for ongoing learning. And those are things like a sense of ownership of outcomes, curiosity, willingness to surface problems. And this mindset emerges from system design, and systems performance actually depends on mindset and willingness of people to lead in solving problems. So what actually what actually causes the shift in mindset. In the bipolar action networks we're starting now, we've really been creating it with this dual engine in mind, system plus mindset. And you can see here in the mission statement that the goal is to improve the health and well-being, but it talks about fostering collaboration and co-production that will result in better outcomes. People don't shift into a learning mindset because we tell them to. They shift because of what they experience. So the kinds of experiences that help people flip the switch are seeing contribution and action, feeling the sense of purpose that takes place when you bring everybody together, witnessing co-production like the examples that I showed, and realizing that your own contributions can make a difference. And what that leads to are behaviors that fuel participation by other people, and engaging and mentoring others, creating opportunities for people to lead. So this is in a network, in the bipolar network, one of the ways that we're building the network is emphasizing the leadership practices that everyone can learn and exhibit. And this slide is one that we used in one of our learning sessions to cause a discussion of that. When this takes place, we start to see examples. This is an example from last week. So last week, one of the clinicians and patients who we call experts by experience started a collaboration. They around pre-visit information gathering. So they have been actively reviewing a variety of digital monitoring tools, which are important for people with bipolar disorders, monitoring sleep, mood, those kinds of things. They recognize the need to balance the doctor's need to understand what's been going on for the patient over a time period with the burden of actually tracking your disease. And so they're now exploring AI tools, and they're working on co-producing a pre-visit checklist that could be used. What's interesting is that this emerged organically from the connections in the network. No one asked them. They actually wrote an email to several of us and said, would it be okay if we actually did this? And we're like, yeah, go for it. That's fantastic. This is an example from the Improved Care Now network where a patient mom, Jane Ware, has a child with IBD, but who also has autoimmune hepatitis. And she recognized that there was a network for IBD, but no network for kids with AIH. And so she mobilized a bunch of other parents to form a network focused on this associated disease. And they've created a network called A-Link, which is the autoimmune liver disease network. In summary, the key attributes of network architecture that make this possible are a sense of shared purpose, which provides directions, shared data, which creates a shared reality. Everybody knows what's going on and can act. Shared learning, which is what fuels improvement, and this shared infrastructure of methods and tools that make learning routine. We began with an email from two parents asking if there was a better way, and that email launched a wave of learning and innovation that's changing how we're caring for kids with Crohn's. This is Seth Khan. He's not just doing well, he's actually become a leader in the community, and he's now teaching other people how to build learning health networks. He's now he's on his way to medical school. He's a coordinator at Mount Sinai in their IBD clinic. And this is what a learning health system makes possible. Transformation not only of care, but of people and of communities and what they believe is possible. And that's because when systems are designed for learning, when purpose is shared, when data are transparent, when contributions are welcomed, leadership starts to emerge everywhere. Whether it's a clinic or a hospital or a national network, every system has the potential to learn, especially if we design it that way. But only if the architecture is in place that turns questions into insight into capability, and capability into better outcomes. And it always starts the same way, with a question and with a feedback loop, just like the one in the email. So I think our opportunity is to build systems where those loops are everywhere, where every question is a potential innovation, where every person is a potential leader, and where every learning is not just a project, but just the way the system works. And so I think that's the promise of the learning health system, and I think it's the kind of thing that we can all build together. So thanks for inviting me to give this talk.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.